Hello, I'm Dr. David McFadden from the Dental Implant Center in Dallas, Texas. Today's topic is full mouth implant treatment, self-diagnosis. I think this is so important for you, especially the ones on YouTube trying to figure out what it is that you want, what it is that you might be able to afford, and what's best for you. And most offices are going to give you a treatment plan that's best for them. They are not going to give you all your options or most likely the treatment plan that's best for you. So the whole presentation today, which again is going to be another long one, will be dedicated to you trying to help yourself figure out what you qualify for. I always show my office at the beginning. Here we are in Dallas, Texas. So again, full mouth dental implant treatment options. I want you to understand all your options by the time you finish this video. And I'm going to teach you how to self-diagnose. I know that's going to be controversial with my peers, but it's so important that you understand all these options so that you don't get undertreated or overtreated. Why is it important? It takes a lot of time, it takes a lot of energy, and it takes a lot of money. Depending on where you are around the United States anyway, you're looking at a monumental expense, perhaps one of the biggest expenditures in your whole life. You might find the lowest end treatment around $15,000 for one arch, upper or lower. You might find something as high as $60,000, maybe even $80,000 for just one arch. For the whole mouth, you're looking at $30,000 to $120,000. So this is a monumental decision that you're about to make. And I would even add to that, many of the treatments, especially All-on-4 and All-on-X, that's a one-time deal. You get one shot at it. And if it doesn't turn out perfect, it's just going to plague you the rest of your life. Your dental future is never going to be the same if you get talked into the wrong decision. And many of you can only do this one time financially. So it's so important. I'm really glad that you tuned in today, and I hope that this process that I'm about to share with you will help you in your journey. What typically happens in most offices? You've got the All-on-4 offices where you get one option, and that's FP3. We'll talk about that here in just a minute. But no matter where you go, if you go to a general dentist who has a sideline in implants, they're going to typically talk you into what they're accustomed to doing. So either way, in most cases, you've heard the saying, if your only tool is a hammer, everything looks like a nail. That couldn't be more true than it is in implant dentistry. So what happens in most places, and I know this is controversial, I'm going to get a lot of blowback on this, but most places you're going to get an improper diagnosis, leading to an improper treatment. And that's what I want to prevent today. So let's talk about this self-diagnosis. Yeah, it's just the best we can do, right? It's the best that you're going to be able to do by feeling your mouth with your tongue and looking in the mirror. But seriously, it's not that hard. I do a lot of Zoom consultations for out-of-state patients, and I only ask for a panoramic x-ray. I've been doing diagnoses off of panoramic x-rays for 35 years. It's pretty darn accurate after you've seen a few hundred or a few thousand. So you typically, all you have to do is look in the mirror. How many teeth do you see? Can you still see some pink gum tissue? So like I say in so many of my videos, if you have some, most, or all of your teeth, 85% of you are going to qualify for something far better than All-on-4. So here's a gentleman looking in his bathroom mirror. He sees teeth back to here, and then there's a kind of a shadow where there are no teeth. But I would argue, and after doing thousands of these cases, I would argue that this patient right here qualifies for FP1 or FP2, and I don't even need to see an x-ray for that. And I'll qualify that by saying every once in a while, I make a mistake on diagnoses. Once we get the CT scan, I can correct that mistake, but it's very, very rare. So this is all you have to do. Feel your mouth with your tongue. Look in the mirror. How many teeth can you see? Can you still see some pink tissue? You're probably a better candidate for FP1 or FP2 than all-on-4. So really, these are the questions. Do you have some, most, or all of your teeth? Can you see visible gum tissue? If the answers to those are yes, you're probably a candidate for FP1 or 2. And I will tell you that many of our denture wearers still qualify for FP2, even though they've been wearing dentures for years. So our goal here at the Dental Implant Center is and always has been preservation of human tissue. We want to preserve the bone and the gum tissues that you come in with. So a lot of the dentists on my YouTube channel push back on my statements and say, well, you're really doing more FP2s than you're doing FP1s. We'll talk about why they say that. But the point is, we want to honor your bone and gum tissues the way you come in. We're going to work with what you have. Unlike the all-on-4 protocol, where they're going to turn you into an FP3 patient no matter how you present. So that's the difference, is this has always been our goal. And as a patient, this should be your goal too. So why would anybody get all-on-4? It's a great question, I think. So there are some reasons for it. The first one is cost. All-on-4 is going to be your least expensive fixed option. So if I'll qualify that also. We do FP3s here all the time. We typically don't use angled implants, but we're going to do FP3 if that's how you come in. So the second reason here is if you're already missing bone, and it's controversial whether it's 15% of you or 25% of you that have worn dentures forever, or you have severe periodontal disease where you're already missing that bone. You present as an FP3 case. We're not turning you into one. So these are your only two reasons really to ever consider all-on-4. But there's tens of millions of dollars being spent every month trying to convince you that it's the end-all be-all of dental implant treatment. But it's really just a marketing ploy. Every patient deserves a unique treatment plan, and every patient should be treated with the bone and the gum tissues that they present with. So all-on-4 or all-on-X always requires bone removal. And in the lower jaw, it's pretty common that we have to remove bone. The reason for that is that lower bone anatomy tends to be very peaked or triangular, and the top of the bone is too thin to place implants. So we do have to remove some bone on the lower much of the time. Not all the time. If you've got really good bone and you still have your lower front teeth, we don't always have to remove bone. But even when we do, it's minimal. We want to just get down to a platform that's big enough for the implant. We don't have to remove that 12 to 15 millimeters that they do in all-on-4. And if you do have great bone and gum tissue, we can give you FP1 in the lower much of the time. But again, we're going to work with your bone the way it is, unless the bone anatomy dictates that we have to flatten your bone a little bit. In the upper jaw, there's only one reason to remove bone. Again, people that qualify for FP1 or FP2, there's one reason. It's called vertical maxillary excess, or the acronym is VME. So let's talk about what that is. Vertical maxillary excess is when the upper jaw grows beyond what we consider to be the norm. It grows downward. And people that have VME typically have a gummy smile. I know many of you have friends or family members that have gummy smiles. And they also tend to have a longer face because their maxilla, their upper jaw, grows downward and it makes the face appear longer. So again, you've seen friends and family members and acquaintances that have this. It's a gummy smile. The technical term is VME. Some people have a very excessive gummy smile. So these are the only patients that really need bone removal in the upper jaw. And we're talking about just a few percent of the population. Maybe as little as 1%. It's very small. So there is one time that we do remove bone in the upper jaw. But I will tell you something about patients like this. Many of them have grown accustomed to this look. And many of them don't even want the bone removed to fix the VME problem that they were born with. It's a big change. But it's kind of mixed. Some people want to fix it, some people don't. So, but again, remember, if you're already missing the bone, that's one thing. But if you have teeth and bone, the only reason to remove bone in the upper jaw is if you have a gummy smile. Here's the graphic for Dr. Mish's classification for full mouth implant treatment. So his classification system was FP1, FP2, FP3, RP4, and RP5. FP1 is when we're able to preserve your bone and gum tissues and give you back just your teeth in their basic normal proportions. FP2 is when we give you back your teeth, but they're slightly longer than what the industry considers average. And FP3 is the large prosthesis that has pink on it. And that would be for patients who come in with already missing bone, or the all-on-4 or all-on-X patients where the bone is being removed at the time of surgery. I talk about that in at least a dozen of my videos, so feel free to go search those, or we'll provide links for you here as well. But FP3 is being done at a ratio of probably 999 to 1. There's 1 in 1,000 patients in the United States being treated today or any given day that are actually getting an FP1, and the remaining 999 are getting FP3. That's because it's become so popular, thanks to marketing. So here's an example of the 3 types of fixed prostheses. FP1, where you get just your normal dimensions of tooth back. FP2, where it's longer than normal. And FP3, where you have the pink that replaces your bone and gum tissues. So it's always kind of a judgment call between FP1 and FP2. Some people like me, I have long teeth naturally. So people would maybe look at my mouth and call my teeth an FP2. So a lot of that, the main thing I want to tell you about these prostheses, when the surgery is done well and the prostheses are made well, they're all very, very cleansable. Convex contours. No matter what the prosthesis, as long as you've got convex contours, they connect to the implants the same. And when we do these convex prostheses, they're very, very easy to clean. You brush and you floss. We don't even encourage our patients to, if you brush and use a water pick, that's all we typically tell our patients to do. If you want to floss, that's great. But we've done so many of these now that we know that about 30% of our patients floss afterwards and 70% don't, but the gum tissues appear pristine either way. Very, very easy to take care of. And unlike all-on-4 or all-on-X, we never remove these. We've got patients that have had these for years, decades. We don't take them out because they're that easy to clean because of the convex design. So then, just to complete the cycle here on the full mouth implant treatment, RP4 is a removable denture that snaps onto implants or implant bars. And the definition between the two, this one is supported by the implants, and RP5 is another removable snap-on or overdenture that is supported by the implants and tissue. And we're going to show you examples of all these, probably more than you want to see. But there's something specific about each one of our cases I'm going to show you today that educates you more on why we do the things we do and what you should be asking your doctors if you go for consultation. This is an example of RP4. You've got implants around the arch, more than 2, so it doesn't move, it doesn't rotate. And here's an RP5 that is actually 2 implants in the front where the denture can still sit on the tissues in the back. I've done many of these over the years, and most patients don't really like the RP5. So we typically try to do the RP4. That's what we recommend on everybody. But to complete the classification, that's what all 5 different categories are. So again, partly supported by, totally supported by implants, partly supported by implants. And again, back to the FP1, we're going to go through these one at a time now. So FP1 is the type of treatment we try to do when patients come in with all their bone and all their gums, which is a lot of the time, way more than 50%. So here's an example of an FP1. 8 implants and teeth just normal size. Here's FP2, just to give you an overview, where this patient has 6 implants and his teeth are a little long. A lot of my critics say that patients don't like long teeth. And that's fine. Some patients don't like long teeth. So they wear temporaries for between 3 and 6 months. All of our patients wear temporaries, so they can decide if the lip sits here and you don't show the length of the tooth, who cares how long it is? It's easier to clean this way. But if you don't like that, during the temporaries, you'll tell us, and we'll put pink on here to make the teeth the length that we think looks best on you. Most of the time, this doesn't show. So long teeth, yeah, this would be an FP2, and my critics say, well, you know, a lot of your cases are FP2, and I don't disagree. But it's up to the patient after they wear their temporary whether they get FP2 or FP3. It doesn't matter to us. It's a personal preference, and we'll do it either way. FP3 then is the one that I like the least. FP3 is what you get if you get all on 4 or all on X. And this is what they typically look like. This is a case where a lot of bone was removed for convenience by the office. This turns everybody into the same patient. So FP3, they can look really nice. I have no qualms. I've said repeatedly on the videos that the smile is the easy part for us. We can give you a beautiful smile, but the foundation is what's hard. If we want to do what's best for you, we're going to leave all the foundation there and try to minimize the amount of pink that you have on your prosthesis. And for, like I said earlier, 15 to 25% of you, you're going to come in with missing bone and you're going to need to have pink anyway. But that's where we're going to treat you how you come in. So what I'm trying to do today is I'm trying to help you understand and prevent you from getting something like this and trying to help you get something like this. FP3, FP1. And again, another one of my videos that I wish more of you would watch is called Lips Retracted Photography, before and after pictures. The all-on-4 centers will not show you this picture. They'll show you the patient smiling, and they might show us a close-up of the patient's smile, but they're never going to show you lips retracted. And this is a very, very typical outcome for all-on-4. When they remove all that bone, the bone in the gum recedes, and many, many times the implant and the abutment show. So the way they get around that now is they make the prostheses go over the implants and over the gum so you can't see the recession. Then it makes it impossible to clean. So again, I'm trying to keep you from getting this and help you understand how you can get this. And I already said it earlier. Why do FP1 prostheses or even FP2 prostheses, why do they represent 1% or less of all the full mouth implant treatments being rendered? That's because of marketing. People are convinced by the all-on-4 centers that what they give patients is the best treatment for them. And it's not. It's just what's best for those offices. It's faster and it's more profitable to do 2, 3, or 4 FP3s a day. When you're trying to do really beautiful FP1s and 2s, we can do 1 of those a day. So again, marketing and convenience for the office is why the market is saturated with FP3 treatments. And there's one primary reason for that. I said marketing and popularity, but the real reason is FP1 and 2 are very difficult. They take way more time and energy and passion to do well than an FP3. So that's really the reason is it's difficult. It's a harder treatment to render by far. So let's go through some cases. Finally, we're through the boring stuff, and I can start to show you some of the examples of what we do here, and we'll go through all 5 categories. So FP1, we start with patients like this, and again, if you're self-diagnosing, you're going to look in the mirror and you're going to see, yeah, my teeth are ragged, but my gums are beautiful, and I have all the tissue between my teeth. Look at how beautiful this is. The teeth aren't pretty, but I look at this and go, this is an FP1 case for sure. So I'm not going to bore you too much with a lot of slides per case, but again, when you see patients with that clinical presentation, we typically see bone, excellent bone everywhere. And again, I believe it's 85% of patients qualify for something better than all on 4. So we're able to take a patient like that, take his teeth out, put implants in. He gets a beautiful temporary to wear while his gums and bones are healing. And then we can give him this beautiful, beautiful FP1 prosthesis. This is a patient from California. He hasn't been back for his follow-up. So we had a little bit of bleeding on the day we gave him these prostheses. That resolves in 1 day. So he'll be back to beautiful pink tissues in 1 day. But that's the sculpting of the tissues that takes so much time and energy. And it's also why things cost more. I just heard a quote from California. Maybe that's why we have so many California patients here in Dallas. They fly in to see us because they're getting quoted $120,000 for this treatment in California. And we are far less than that here in Dallas. That's a really nice FP1 case. Turns out with a beautiful smile. And there's his post-operative x-ray. 8 implants in the upper, 7 implants in the lower. And the more implants you have, the smaller you can make the prosthesis. So people ask me, why do you guys place so many implants? And the reason is, the shorter the span between implants, the stronger the prosthesis. That's how we can make FP1. And a lot of the all-on-4 centers tell you they have to remove the bone because you need the zirconia to be really thick for strength. Well, that's true if you're only using 4 or 6 implants. And you'll also notice that we don't angle our implants. If the bone allows us to work with a straight implant, that's far better for us, you, and the bone in the gums. So here's the second case, FP1. Patient comes in with missing bridges. I didn't have a pre-op on her on our recent radiographic software, so I showed you the first X-ray after her first treatment. Look at how much bone this woman has. It's fantastic, and you can tell that. Here, like you could see in the mirror. Look at all this beautiful tissue, the bulk of it. Even in the back, she's got fantastic volume. If she'd have gone for all-on-4, they would have taken all this away. She would never have a chance to have a nice-looking prosthesis again with her lips retracted. So lots and lots of bone, so she qualifies to be an FP1 case, and we do her in a transitional way. The reason her previous work failed is the doctor over-prepared the teeth, and the bridges were falling out within 2 weeks of getting her permanent bridges. So we put our first set of implants in and gave her this beautiful temporary, but when you manage the bone and the tissues and the temporary bridges properly, you can develop or maintain contours like this, and now the teeth just fit into that frame, just like this. And I think most of you would never, well, even a dentist looking at this could not tell whether these were implants or crowns on teeth. And that's our goal, is we want to reproduce the prettiest possible smile you ever had, or better. And the only way you can do that is with FP1 or FP2. So here's her post-operative x-ray. You can see all the bone she came in with, she still has. That's the important thing. And then she went on to do her lower arch a couple years later, and this is what it looks like. Then we've got a third case. I want to show you another patient who comes in with a lot of missing teeth in the back of her mouth and only 6 front teeth. But again, just like when you look in the mirror, Look at her gum tissues. There is no reason that's in the best interest of the patient to remove bone up to here. No reason. So she did not have bone in the back of her mouth. So she did have to have, her sinuses drop way down here, so she did have to have bone grafting. But to get this kind of an outcome, it's worth it. So it takes a little more time and more money, but if you can maintain what's there and enhance what's not there, why wouldn't you? So we did bone grafting in the back. We ended up placing 6 implants. And another beautiful temporary that helps shape and guide these tissues to stay healthy. And this is the case I showed you earlier, the FP1 size teeth. And that's her outcome. So again, even if you present without the bone that we need for these FP1 and FP2 cases, many times we can add it back. It takes a little longer, costs a little more, but to get a result like that instead of a big, huge prosthesis, I personally think it's worth the time and the money. So this is what her post-operative x-ray looks like. She had the good bone in the front that we used. We added bone in the back, and she's extremely happy. In fact, she just filmed a little Facebook video for us. So now let's move on to FP2. As you may recall, FP2 is similar prosthesis, just with longer teeth. So here's a case. This is one of my favorite transformations of all time. This guy had lost so many teeth and lost what we call vertical dimension. His face had collapsed. But again, like I'm telling you to do in your own mirror, look in your own mouth. Look at how robust and how nice his tissues are. So instead of cutting the bone away, we're going to work with what he has. So here's his preoperative x-ray. He doesn't have good bone in the back of his mouth, but he's got great bone here in the front of his mouth. So we're going to use it as it is. He got this many upper implants and 6 lower implants. Nice temporaries on the day of surgery. And this is what we can do to the tissues if we're careful. If we preserve your tissues and we make nice temporaries, we can improve the tissues much of the time. And this is his final result. So again, yes, these teeth are long. And some of you may object to the color, but that's a personal preference. Whatever you want is what we'll do. If you want bright white, you get bright white. This gentleman wanted what we call age-appropriate teeth. So that's why they have a little bit more character to them. So the teeth are longer than we think is normal, but his normal smile, there's his post-operative x-ray. Before and after, I wanted to show that. I think it's so profound. But with his smile, you never see the long teeth. But if he objected to that, we could easily have added pink porcelain, no problem. So this splitting hairs between FP1 and FP2, FP2 and FP3, it's just silly nonsense. We're going to do what we think looks right, but if the patient's opinion differs, we can pivot easily and add pink to these cases. So technically they would be an FP3 instead of an FP2 for all you haters out there. But the point is, we're going to work with your bone the way you come in. If it ends up being an FP3, fine, but we're not removing your bone. Here's the second FP2 case. And this is what's so shocking. This is why I definitely wanted to show you some of these cases. This patient is a denture wearer. Many of you are. That does not disqualify you from FP1 and FP2. That does not mean you have to go to FP3 or all on 4 or all on X. And this is a perfect example of that. Even little areas of bone like this, we'll try to use them. If we see on the CT scan there's bone available there, we'll use it. So good bone up here, excellent bone down here. So we treat this gentleman with some procedures. I try to manipulate bone. I know that may sound like a weird phrase to you, but in the back of the mouth there's techniques we have where we can lift your sinus without doing a bone graft. That's what I did for this gentleman in those 2 areas where he had some bone back there. I want to use it if I can because it gives him a longer prosthesis without cantilevers, and that means without unsupported teeth sticking off the back of the prosthesis. So anyway, he got 8 uppers and 5 lowers. But you can see after he wore his first temporary for 3 months that we're actually getting some of these papilla back. His bone and gum tissues were so good that we've actually reproduced, recreated, redeveloped some of this anatomy that we consider to be so precious. And he didn't have it to start with, but by handling everything conservatively, we were able to bring some of that back. And then he gets a result like this. FP3 in the lower, FP2 in the upper. And just like the other patient, he doesn't show that when he smiles, so who cares if the teeth are long? If you care, we'll add pink. But anyway, FP2, FP3 on a patient that had an upper denture, a lower partial with failing teeth, and a history of periodontal disease. The other big pushback I get from other doctors who are critical of my videos and my statements is that all our patients already have periodontal disease. That is not true. It's less than half of our patients actually have periodontal disease and bone loss. But even when they do, they don't have to be subjected to all-on-4. So that's the case I wanted to definitely show you. His post-op result radiographically. The next case on FP2 I think is also interesting. Here's his case, but I look at this case and say, wow, look at that bone. It's amazing. There's no reason to cut it away. So we're going to try to give this gentleman fixed prostheses in both arches so that he can have easy to clean and something he can be proud of while maintaining his tissues. This gentleman did come in completely edentulous, meaning without any teeth at all. He didn't have great bone back here. It was very narrow in the back of his jaw, so we stayed here in the front, but he did have excellent bone back here, and by adding a little bit of bone ahead of the implant, we got implants further back than you'd expect. So he wears temporaries for some amount of time, and again, in a denture wear, we're able to recreate some of these precious papilla. And again, he had great bone, even though he wore dentures. And all of this is fantastic. To be able to see this amount of beautiful tissue, that's our goal. Same thing on the lower. There's some surgical techniques that we've developed to enhance tissue when it's not perfect. But here's his outcome. He was another patient that wanted bright white teeth, so we gave him bright white teeth. FP2 up here from a denture, FP3 down here from a denture. So the other thing I hear from patients who come in for second and third opinions is that they're always told, you don't have bone, you have to have all-on-4. And I can tell you that probably only 15% of the time is that true. Most patients can have something even if they've been told they don't have bone. And his smile, so even though those teeth are long, no problem. Very rarely do patients show that gum above the teeth. So there's his final x-ray. So let's move on to FP3. These are patients who either found us after getting all-on-4, or they didn't have bone to start with, or they had periodontal disease. So imagine, I would call this a mutilated dentition or a terminal dentition. But again, as you're looking in the mirror, he does have tissue. He does have tissue and bone. His problem was cavities. And that actually, cavities and broken teeth are the majority of the patients who come in. It's a fallacy. A lot of my colleagues trying to justify all-on-4, it's a fallacy that most patients have periodontal disease. In our practice, the majority of people have lost their teeth to cavities or breakage from grinding. And this is a perfect example. So we were able to start with this amount of bone. Again, I look back here, excellent bone, excellent bone, excellent bone. So he's actually got a great candidate for full mouth implant treatment. So in his case, he had to wear a large temporary because he had lost his normal position to show his teeth when he smiled. The teeth had to be brought down a long way, so he had to have pink on even the temporaries. But look at his tissues after wearing the temporaries for 3 months. Beautiful. You would never expect that from the first slide, I'm sure. Lower tissues equally as good. And here's his final result. FP3, FP3. And these are large FP3s, but that's what his bone dictated. His anatomy, we didn't remove any bone, his anatomy dictated that he had to have a large prosthesis, and that's fine. And again, his smile would have shown some of that, the openings if we hadn't used pink. So these are cases where we have to use pink, we have to do FP3s. There's his final result. Okay, FP3 case 2. This is a patient who found us after getting treated elsewhere. She came in with really bad overdentures. These are abutments to hold the dentures in place. So sometimes we can use existing implants and sometimes we can't. If we can use them, we will. If we can't, we'll either take them out or cut them off and put them to sleep, we call it. Take them out of service. So in her case, she had bone everywhere, really good bone everywhere, so I went back and added implants to the ones she already had. And on the lower, the same thing. This is one of the ones that she had. It was still obviously not completely healthy, but we hadn't planned on putting an implant behind there, and I thought later after she had her first surgery, I said, you know what, we'll leave this implant, but if it ever fails, we'll put one behind it to use in the event of failure. So again, she was missing all this bone when she got here. It could have been from the first surgery, or it could have just been from bone loss before the first surgery, but a very large prosthesis, an FP3, replaces teeth and gums and bone. Same thing on the lower. But again, I'll tell you that these are just as cleansable as our FP1s and 2s because we contour the bottom properly so the patient can clean it on their own. And that's what it looks like in her mouth. And I have to compliment the lab on this. This is beautiful, beautiful work with beautiful staining to make the zirconia match her own tissues. So in a case like hers, we have to use pink because it would show. That open space between the teeth would show. Or we'd have to make the teeth too square. So really nice FP3 case. And this was really a rescue case. She came in with some implants. We used some. We had to take some out of service. And why do we do it that way instead of just remove the implant? Even badly placed implants or failing implants, sometimes when you try to remove them, you take a lot of bone with it. So this is perfectly healthy. The bone and the gums heal over this, and most of the time these are never heard from again. So we take them out of service rather than compromising the bone by removing them. Okay, FP3 case 2. Here's a patient, like I've been telling you, self-diagnosis. Look at all this tissue here. And she found us, she came from Massachusetts to see us. She found us because she wanted to try to do the no bone removal. So her case, actually, she had deficient bone up here because, as you'll see, she didn't have any teeth up here for decades. But let me go back. Look at the bone here and here and here. So all this plays into how we look at patients for what we might accomplish for them. So she has really good bone elsewhere. So again, like the other one I showed you a few minutes ago, she went through bone grafting up here. We added bone so we had more thickness so we could place implants up here and she could have the smallest possible prosthesis. But the other thing you'll notice on the clinical slide is that you can almost look at her. Teeth are supposed to overlap the lowers by a few millimeters. So her smile was already deficient. Her teeth were already too high this way. So in cases like that, we can often warn the patient that they're going to have long teeth or need FP3, but it's not because we're turning them into that patient. And you'll see later, this is a great case. I wanted to show it to you because it demonstrates one point that I want to make for those of you who may fall into this same category. When we take her bridge off, I don't know if you can appreciate this, but there's a big concavity here and a big concavity here where her bone was really thin because she had been without those teeth for decades. So we did the bone graft, we placed her implants, and we made her this beautiful temporary, and the teeth were long, and she didn't really like that. And honestly, I don't really like it either. But you can see how much bone we built up here to be able to give her 2 front implants. But the back of her mouth, she had bone already. So we were able to just use it the way it was. So she gets, she told us that she didn't like the long teeth. So we pivoted again and we added pink back here, which is perfectly fine. So she could have been a long FP2 case, or she's a normal, actually kind of a smaller FP3 case. But again, this is why she would have had really long square teeth to fill in these areas. But by adding pink, we can give her this beautiful smile where she was ecstatic. We just finished her last week and she was ecstatic. So a case like this where you can get that many implants in, another thing I wanted to point out to you is that just like I said on the last case about removing implants, sometimes we injure the bone, or we cause the bone to break or be resorbed. Canine teeth, especially root canal canine teeth, sometimes we leave them. 2 things will happen. We leave them because they're so hard to take out that we can break the bone, and by now I know that you know how precious the bone is to me. So if we wiggle them and they don't wiggle, we often leave the canines, and sometimes other teeth as well if they're hard to get out. That tooth will either come out on its own over the next few years, at which point we'll just pluck it out of there real easily, put her bridge right back in, no problem at all. Or the bone and the gum tissues will heal over it and we'll never hear from it again. So that was something I wanted to point out to all of you. Is the other advantage to leaving roots in place is you don't get as much shrinkage of the bone afterwards. We know that when we take teeth out, we get shrinkage of the bone, which causes shrinkage of the gum. Leaving some of these roots in actually prevents that. Okay, I'm going to call on one of my other doctors now to present the RP4, and these are the removable options. Why would people get removable over fixed? There's a couple reasons. Cost is usually the main reason. They're less expensive. Sometimes half as expensive as doing the fixed. And the other reason is sometimes patients just don't have the bone to do fixed, and they have the bone to do fixed, but they don't have lip support. So when we do removable prostheses, they're basically modified dentures that snap onto the implants. We can give them lip fullness where they wouldn't have it otherwise. So anyway, that's my part of this presentation. Thank you for listening, and we'll go through these last 2 classifications next.
Alright, now we're going to be pivoting. Instead of going from the fixed world, we're going to go on to removable prosthesis on dental implants. The first classification we're going to be talking about is RP4, or removable prosthesis 4. If you recall the earlier definition, an RP4 prosthesis is when the prosthesis sits primarily on the implants, or it gets support from the implants. This is a case where the patient presented with a pretty mutilated dentition, pretty much end stage. He knew he needed to have all his teeth out, and he knew he needed dental implants as an option. Because of cost constraints, he decided to go for the removable treatment option. So this is preoperative radiograph. You can see that there's a good amount of bone loss around the teeth. There's quite a lot of recession going on. There's a lot of dental decay going on as well. He had all his teeth removed, and we allowed him to heal for a couple of months. The tissues could close up, and we went back in to place dental implants. So these are locator abutments. One of the things that patients often forget is that a dental implant is just a screw. The screw sits in the bone. The magic comes in terms of what we do on top of the screw, and this is just one of the options that you can have done. These serve as little attachments and buttons for the dentures to click onto so that the dentures are able to snap on and off. Same thing for the lower over here. And that's what the restoration looks like at the end of the day. It's an overdenture. You have little attachments in the middle, and those attachments can click onto the abutments in the mouth. This is a view from the front of the mouth, and one of the things you'll also appreciate is that there's a very large amount of plastic up here, and that's called the flange. Another reason some patients choose to do a removable option, even if they don't have a cost constraint, is that they need to have some amount of lip support. This flange here is perfect for providing the lip support. The problem is, if you try and have something like that screwed into the mouth and bolted down, it's going to be completely impossible to clean it. In that situation, a removable prosthesis will be your best bet because that way you can take it out, give it a good clean, and put it back on again. That's the patient at the end of the treatment. Final outcome was beautiful. So the second case that we're going to talk about is an even more classic RP4 design. In this case, there is a bar that is attached to the implants, and this stays in the mouth. The denture, on the other hand, will sit on top of the bar and be attached in a different method. This is the underside of the denture, and this, for the more engineering-minded of you, is called a spark erosion prosthesis. These pins on the side of the prosthesis are the retentive features where it snaps onto the bar in the mouth and the whole denture doesn't move that way. This is a view from the other side, and one of the reasons we don't really recommend this kind of prosthesis anymore is because they work very well the first time, but over time, the acrylic on this area here will undergo wear and tear, it begins to break down, and you need to have some kind of servicing done. Anytime you attempt to resurface a prosthesis like this, it becomes close to impossible to have it fit properly again. So maintenance is an extremely difficult procedure. The second reason is more for manual dexterity. For patients who are older or who are not able to reach around and disengage this kind of screws, it becomes a lot more difficult for them to use the denture over a long period of time.
So the last classification that we need to talk about is RP5. What is RP5? It is a removable prosthesis. Similar to RP4, the difference is the way it's supported. So in an RP4 situation, my colleague Dr. Tan just explained that it's fully implant supported, which means your gum tissue is not loaded in any way. With the RP5 situation, it becomes a little different. What happens is the implants are there and they assist with the retention of the denture, which means it resists you trying to take the denture out, which helps with that retention of it. But in terms of support, it provides a little support, but the majority of the support still comes from your gum tissue, which means that if you were or are a denture wearer, and you would understand when you bite down, your gum tissue under your denture would be the one supporting the denture predominantly. The benefits for RP5 prosthesis is for patients who don't mind feeling the pressure on the gum tissue with their denture, but they just need an additional bit of retention so that the dentures don't keep popping off. So to show a case, this patient came in wanting dentures, and as you can see, not many of his teeth are left. And so we went ahead to place some implants for him. Now typically with the RP5 situation, we want to place 2 implants in the front, and that will be sufficient for retention. What our experience has been is that when patients start off with 2, sometimes some of them feel like it's still kind of wobbly and they want more implants, and so we can always go back and place a few more implants for them, in this case 3. And so how the denture is attached to the implants is with a housing and an attachment. The attachment are the different colored inserts that you see on the screen over here. So we have different colors which indicates the level of retention that you can have, which starts from low all the way to high, and so it's all color coded differently. So we can start patients off with a lower level of retention, and if they need more in the future, when they need to change out the attachments, we can always change it to a higher form of retention or higher level of retention. So these are the completed prostheses. These are dentures, obviously, and on the bottom we have an implant retained overdenture. So the second case would show another example of RP5. Normally when we do RP5 prostheses, we try and place the implants in a position where in the future, if possible, and the patient knows that they might want to upgrade the prosthesis, we can actually convert it, add more implants and convert it to a fixed situation. There are some patients who are very sure that they do not want a fixed prosthesis for cost reasons, and in those cases we can just leave it as an overdenture. So this patient came in and he was seeking treatment for his dentition, and so we went ahead and placed the implants for him in order to provide him an RP5 situation. So on the image over here, you can see the attachments on the underside of the denture, and what you can also see is the back ends of the denture where it's actually contacting the patient's own soft tissue, the gums, and that's also where a lot of the support for the denture comes from. So this is the final result. It's indistinguishable from a denture unless you take it out and look at the underside where you can see how it's attached to the implants, and the implants actually provide a really good source of retention for the denture. So this denture is not going to pop up unless the patient wants to pop it off. And so this is the final x-ray. You can see the little metal housings that hold the attachments that are fitting over the implants, which gives it the really good retention for the snap-on dentures.